Okay, so I think that the number of people joining us has stabilized. And without further ado, I think it's time for us to start. Um, so welcome and good morning, good afternoon, good evening for those online that are watching us from different parts of the world and also from the European region in particular. It's a pleasure to have you with us. Thank you for joining this webinar. This is, as you know, the last webinar of our series of the WHO Europe webinar series on alcohol in public health. We are very pleased to have you joining us. And as you know, this series was launched in May 2023. You have been with us for this long period, always very active and very attentive also to the series. So thank you for that. And you have been using this as a resource, which is the aim of these webinars. It's not only a resource, but also a platform to exchange knowledge, to share knowledge for everyone who has an interest in alcohol from a public health perspective. So this webinar series is also linked to the Early Career Researchers course, which our program has launched to build capacity among professionals who are in the beginning of their careers. And many of you have joined us physically, many online, and in order to prepare also the work of these early career researchers, we have been linking the two activities together on the topic of alcohol in public health at the national and also at international level. So please note that the webinar is being recorded so that we can have other colleagues that might watch it later on the website of our Avid Action Alcohol Project. This project is funded by the European Commission with the main objective to use scientific evidence to promote and facilitate implementation of effective alcohol policies in the EU, Iceland, Norway, and Ukraine. Some of the key outcomes of the Early Career Researchers course will be presenting in the upcoming conference, which you can follow also online on the 13th and 14th of September, and more information will be provided to you in the chat. Today, we have the final webinar. We're very excited. It has been, as I mentioned, very interesting to be with you throughout this period. Very interesting to see your excitement, your eagerness to share the knowledge, to use this as a resource. And this will be also the final online module in the Early Careers Research course, which is dedicated to the topic of alcohol cultures and stigma, a very important topic for us. By alcohol cultures, we mean that everything which sets our social behaviors, conventions, traditions that surround the consumption of alcoholic beverages, and this, as well as the social attitudes toward drinking, may vary and vary a lot around the world, as well in our region. I have been working in the African region as well, and for example, there most people do not drink. So we do have different cultures, and with that we have different ways of perceiving alcohol consumption, and we have different stigmatization as well coming from that. When we look at Europe as the region with the global highest drinking levels and the lowest numbers of people abstaining from alcohol, we have a completely different panorama. And we need to acknowledge that alcohol consumption is common, is normalized, and it has been part of the European cultures for a while. However, also, we need to understand and acknowledge that harm is caused by alcohol, and this has been part of the European culture for as much as long as its consumption. So therefore, no culture is static, and all cultures change as social norm changes, and I have been seeing this in my experience throughout different regions in the world. So in today's webinar, we're going to explore this area of tension between how normalized alcohol consumption is in today's Europe and how available, affordable, and heavily promoted is alcohol, and yet how stigmatized people are who are reaching out for help in relation to their alcohol use. So an interesting discussion and interesting also panorama where we have, many people drinking, but also many people being stigmatized. We are going first to hear from Baroness Ilora, Finlay of Llandaff, who is a professor of palliative care at Cardiff University School of Medicine, and who has been chairing the Alcohol Harm Commission in the United Kingdom in 2020. The commission was established to examine the current evidence on alcohol harm, the recent trends in harm, as well as the changes needed to reduce the harm caused by alcohol. Professor Llandaff will tell us more about the report of the commission titled "It's Everywhere: Alcohol's Public Face and Private Harm," which already alludes to how alcohol is everywhere, and yet the harms of it remain in the shadows. We will then hear from Professor Schomerus, who is the chair of the Department of Psychiatry and Psychotherapy at the University of Leipzig in Germany. Professor Schomerus, he will tell us more about the concepts of stigma and his latest research on stigma and mental health, with a particular focus on substance use disorders. After the presentations, we will have enough time for discussions, and everyone is welcome to submit their questions on the two experts that we have via a chat function and via the Q&A function. So thank you very much for being with us, and I will now hand over to Baroness Finlay to share her reflections on the main findings of the Alcohol Harms Commission report, which we'll have and will be sharing with us, with you all in the chat. Thank you, and please, Professor, the floor is yours, and you're welcome to start your presentation. Thank you.
Thank you very much indeed. I'm going to share my screen, which I hope will work for all of you. And I'm going to tell you about the Alcohol Harms Commission that I had the privilege of chairing. And I'm also going to put it in somewhat of a legislative context, because as I'm in the House of Lords, I'm heavily involved in legislation. And I can tell you, I'm going to finish up with one of our successes, but of course, tell you about our failures as well. In fact, two successes that we've had. So we entitled our report, "It's Everywhere," because it really is everywhere. And that's what we heard. We had 140 evidence submissions from a very wide range of people. We held oral evidence sessions with 39 witnesses. We held them in England and in Wales. I had 17 commissioners on the panel with me, and we heard a wide range of stories, but often with very consistent messages. And what we heard loud and clear was, whilst everyone's at risk, there are some particularly high-risk groups, those of a lower socioeconomic background, and that becomes important later on to remember. That there's those later middle years that are particularly at risk, 55 to 64, men, people who are homeless, people who've come out of the armed forces, who've been traumatized by what they've seen, and then those who view themselves potentially as slightly different in society, the LGBTQ plus groups. That's not to say that everybody in any of these groups has an alcohol problem, but we heard about risk factors here. We also heard about why people drink. Some people drink to self-medicate with a mental health disorder. Some start drinking and develop a mental health disorder, but they drink to cope with their mental state. And one thing that we heard loud and clear was older people, particularly if they've been bereaved, if their children have left home, if perhaps their job is winding down, they feel they've lost a purpose in life and they bury themselves in increasing alcohol consumption. But we've seen the same in younger people as well, who feel that they don't know where they're going or what they're doing. And in younger people, we heard about the link with drug abuse too. We became aware of the risk of morbidity, even at low levels of drinking. The fallacy that it's safe to drink at low levels, and that actually overall life expectancy is shortened by around 23 years. That's a massive amount of life to lose. And that's all causes of death. This isn't just liver failure. This is overall in people who drink heavily, and then obviously fetal alcohol spectrum disorder, and the tragedy of that, where the woman is drinking before often she realizes that she's pregnant. We heard that a staggering number of admissions to emergency departments are alcohol related, up to 70% in some places. Really wide, high numbers. And we heard about the cost. 1.26 million alcohol-related hospital admissions every year. And as we were told in our evidence, we shouldn't be allowed to forget that even at relatively small amounts, it's toxic. But then we have heard about teenagers too who binge drink for the first time, get admitted with alcohol poisoning, people admitted with liver failure, road accidents, all kinds of things. It costs the health services in England and Wales £3.5 billion a year. But we also heard about staff abuse from people who are under the influence of alcohol, the problem of obesity, the fact that many people are completely unaware of the high calorific value of alcohol and it's linked to obesity. We heard about the unique teachable moment, how the person who presents in A&E that might be the moment to realize that actually their attendance is related to their alcohol problem. And we heard about the high rates of absenteeism and the cost to the nation's economy overall. The lack of treatment services, only 1 in 5 people who need treatment for alcohol problems are actually accessing it, and very, very few whole family approaches. And where there are services, they're often poorly integrated with others. Some emergency departments now, thanks to Professor Robin Touquet, who really led on managing alcohol problems in emergency departments, that many now have an alcohol working team, but that's often not there at nights and weekends, which is when many people present. And we heard about the link to other addictions, to drug use, and to other addictions like smoking, like problem gambling, video gaming, and compulsive spending. So the whole addictive program linked in there, and of course vaping as well, has now come in to replace smoking as an addictive substance. We heard about the enormous number of children affected by alcohol abuse. These came from the Children's Society, these illustrations done by children. And I'm really struck by this one. I beg you to stop. Please listen to me. Please, it's me. But I can't help you. You pour another one. And I try attempt after attempt, but nothing I do helps you. The children aware of the devastating effect of alcohol on their family life, but they are in silence. Their pleas go unanswered. They're not listened to. And they are not listened to either by the person who has the alcohol problem, and they're certainly not listened to by others around who blank out, don't want to refer to it with the child, almost as if they think the child hasn't noticed and they're frightened of raising it. So we became concerned about schools where the school teachers and the people at the school gate may be aware that the parent has a drink problem, but they don't know what to do about it or how to begin to raise it. And this was a very powerful testimony just from one of our witnesses, describing that it was being like a cage, but the safest place possible was her own room. I was too scared to leave or talk to anyone. The solution was to be invisible and quiet, hoping she would not come after me, but she did. She abused me and my dad mentally, emotionally, sometimes physically, for years on a regular basis. This I thought was particularly powerful because often alcohol abuse and violence is in people's minds associated with men. but it can be the women, the mother too, whose mood changes and becomes violent towards the children. And this one, my mum smoked and she set the house on fire when drunk when I was 14. We were all very lucky to get out alive. We only did it as my sister, aged 16, woke up. We heard from the fire brigade in London alone. In 3 years, there were over 1,000 alcohol-related fires. That's equivalent to more than one fire a day directly related to alcohol abuse. We heard about the number of pedestrians who are killed or injured. The casualty estimate, over 300 pedestrians, over 100 cyclists, and that includes 60 children. These are innocent bystanders whose lives are changed, sometimes with life-changing injuries or even killed because of alcohol out there on the streets, intoxicated people. Scotland was very interesting because we heard evidence that in Scotland, the most deprived groups are 6 times more likely to be admitted to an acute hospital and 13 times more likely to be admitted to a psychiatric hospital for alcohol-related conditions than the least deprived. Now, remember I said at the beginning, we heard that deprivation overall was linked to problems related to alcohol use and abuse. Scotland has been renowned for having the highest problem over alcohol, and Scotland tried to do something about it. So what did they do? Well, they introduced minimum unit pricing. It was very controversial. A lot of people tried to object and tried to say that it didn't have any effect. But actually, there was a report written by the Public Health Department in Scotland, and their key finding was that the report estimated a 13.4% fall in alcohol-specific mortality in Scotland due to minimum unit pricing, and a more than 4% fall in acute hospital admissions related to alcohol. Minimum unit pricing had showed a significant reduction in deaths and hospitalizations, as I said, that this was reductions of those situations wholly attributable to alcohol consumption. So it wasn't that alcohol was an incidental finding. This was where alcohol seemed to be the causative agent. And importantly, the greatest improvements were in the 4 most socially, economically deprived deciles. So this policy seems to be positively tackling deprivation-based inequalities in alcohol attributable health harm. That's really important. The other thing was, of course, that the alcohol industry really opposed this. This report had some harsh criticism, but if you want to see the report, the paper around the report, analysing it, it was published in the Lancet. The report itself is up on the Public Health Scotland website. And the UK Statistics Authority became involved because of the criticism. They focused on how the statistical evidence was presented. And Sir Robert Choate, who's their chair, in a letter, open letter, said the findings in the final Public Health Scotland report are communicated clearly and impartially. Their findings were endorsed. There was a small criticism that came from the UK Statistics Authority that resulted in a small correction in the way that a part of the conclusion was written, but it did not undermine at all the findings of the report. So this has been very important because it's shown that minimum unit pricing does have an effect, and actually has an effect on the very group who are at the greatest risk of severe alcohol harms on their lives and their life expectancy. The other thing that I should say that's in the report that's important is that there was no negative impact on the alcohol industry. There'd been enormous concern that this would affect the whiskey making industry and other alcohol industries in Scotland, but actually minimum unit pricing was not shown to have an adverse effect on that industry. That becomes important because, of course, a lot of criticism of minimum unit pricing was brought forward by people who, one way or another, have an interest in selling alcohol. Then in the budget for England and Wales, the Westminster government introduced a draft duty, which was is a very innovative initiative, which is saying that rather than putting up the duty on all alcohol everywhere, that where alcohol is sold on draft, so in pubs, in public places where the drinking is visible, where somebody might say, no, you've had enough, you're not to drink anymore, that actually the duty is not as high as it is in supermarkets and off sales. And we know that the price reductions, the bargain booze type sales, where people would buy alcohol, drink at home, drink behind closed doors, out of sight, are particularly linked to alcohol abuse. And that became very, very evident during COVID. It also has been important because it has set a precedent. You can have different levels of taxation within alcohol itself. So where it's sold, how it's sold, the amount of tax on it is different. And that allows a little bit of gradation to happen. But obviously there is a major problem, and COVID really revealed it, of drinking at home. What other attempts have we had at introducing legislation? Well, Lord Brooke of Alverthorpe this year had a private member's bill trying to lower the alcohol limit in drivers, because in England and Wales it's particularly high. It's 80 milligrams, which is dangerously high. In Scotland they've now dropped it to 50, and so England and Wales have the highest in Europe. His bill didn't get anywhere, but I think he's going to try and introduce it again after the next state opening of Parliament. Obviously, there's resistance to it. My personal preference is that I would like to see it drop to 20, so that the message is there that actually, if you've got the car keys, you don't drink. Simple. And I think we've seen very clearly with all of these public health messages that straightforward, simple messages have impact, complex messages don't. So I do worry that messages around units of alcohol are really almost impossible to understand. I find even I can't work out how many units in one glass or another glass or whatever. And you just need a very simple message. If you've got the car keys, you don't drink. If you've had a drink, you don't get in the driver's seat. Simple, straightforward. And that should also apply, of course, to whether you get on a bicycle or on a scooter, because you can not only harm yourself, but you can harm other people by cycling or being on a scooter or being in control of any type of machinery if you're drunk. We had an alcohol labelling bill trying to improve alcohol labelling. That didn't get anywhere in the end, although alcohol labelling has slightly improved about warnings in pregnancy. The public health message associated with that shows a heavily pregnant woman. And of course, we know that the fetus is particularly damaged early in pregnancy, even more than in late pregnancy. So the effect on the developing brain is particularly severe early on. And also the little symbol about not drinking in pregnancy is so small that I've come across people socially who haven't known what it was or what it was about, because it's a tiny little symbol on the corner of a label. In the Police Reform and Social Responsibility Bill going through, I had an amendment about alcohol monitoring being put in as a scheme in youth rehabilitation orders, where young people have committed a crime and are sentencing to a rehabilitation process. But I was defeated. So that fell. But there was one success. The other one, of course, that I've referred to has been the minimum unit pricing in Scotland. But this is one which I'm really quite proud of. And that was in the Legal Aid Sentencing and Punishment of Offenders Act, where I persuaded the government to pilot a sobriety scheme. This was based on North Dakota's experience of alcohol abstinence as a sentence, with a monitoring requirement every day. In the US, they have done it by breath testing people every day. For a whole lot of reasons, we couldn't do that, but people have a tag which detects alcohol in the sweat, and has had a remarkably high success rate of people remaining off alcohol during the month of their sentence, and a high success rate of people remaining off alcohol later on afterwards as well. So having the ability of a court to sentence somebody where alcohol has been the fueling agent of whatever their crime is, to be able to sentence them to sobriety has been effective. Now, this does not cover people who have a long-term addiction, who really need treatment. This is people who've been binge drinking inappropriately, who are on the beginning of that escalator towards alcoholism, who are on the beginning of thinking that it's okay and it's fun to have too much to drink, and possibly are doing that with a degree of alarming regularity. And we know, of course, that students, young people under peer pressure often will have alcohol and drugs in really dangerously toxic and potentially fatal mixtures. So that's been one thing that we have introduced, and that has been helpful. And I was very grateful to people from North America who shared their experience of their scheme and enabled us to get that through as a pilot. And the pilot showed efficacy, so it's now been rolled out. So thank you very much. I hope that's given you a quick rundown of what we've done with our report, what we found, and how we've tried to push government to act on the findings of the report. But of course, there are all kinds of pressures against us in that. Thank you.
Thank you very much, Professor Finlay. The report is online we have shared the link. And thank you for the highlights of the focus of the report. Thank you for really showcasing the harm to self, but also the harm to others. I think that you highlighted very well some of the topics that many times I've forgotten in terms of the harms to others and how huge this harm to others is, including for children, for the family, and for the society. And there are those voices that many times are not heard, but need to be more and more into the public domain and heard and be given the floor to really speak up on the harms that they also suffer. And also you highlighted the policies that impact and that can protect people at populational level. Thank you for highlighting that, and also for highlighting the need also for specific support and treatment for those who are also have an addiction problem and will benefit from more specialized services and care, which many times is not available, and also needs an investment to be able to have support. So now, without further ado, I'll give the floor to our next speaker, Professor Schomerus. Please, the floor is yours, and you will be talking to us about the stigma of alcohol use disorders.
Yeah, thank you. Thank you. That's a great talk to follow, really, because we heard that alcohol is everywhere, and I would add that the stigma of alcohol use disorder is also everywhere. So wherever you have alcohol, you have the stigma attached to it. It really is the elephant in the room when you are dealing with alcohol problems. And we have published a book on this, which you might be interested in. But there are several systematic reviews who have examined the stigma of alcohol use disorders in comparison to the stigma of other mental illnesses. And they have found that first, the rejection of people with alcohol use disorder is particularly strong. They're kind of in the lowest hierarchy of stigmatized people. And the stigma is characterized by blame. So while people with depression, they may feel that they are blamed, but actually nobody really blames them for their illness, and even less so with disorders like schizophrenia. But if you have a substance use disorder, you are heavily blamed because people assume that you are responsible for your illness. So although alcohol use disorder has been a proper psychiatric mental illness for more than 50 years now, still many people think it's first and foremost a personal failure if you actually have an alcohol use disorder. How do people experience stigma? There are many terms and aspects of stigmatizations. I just put them together in this crowded slide, but I try to give you a systematic, since I'm German, overview of how stigma actually interferes at many levels with the lives of people with alcohol use disorders. We have three columns of stigma. It's public stigma, self-stigma, and structural stigma. And all these types of stigma, they are enacted and directly experienced, and they're also anticipated and avoided. And I will argue that both have severe consequences on the lives of those who have the disorder. I mean, enacted public stigma, that's kind of the stigma that pops up in your mind first when you think of stigma. That is the devaluation that someone experiences when he is intoxicated and calls the emergency doctor and is treated condescendingly, for example, because he's drunk again, and being drunk is just a state that provokes everybody just to be unfriendly to you because obviously you have made a mistake, you have drunk too much. And so I think people with alcohol use disorder experience a lot of unfriendly and discriminating behavior by others. And because they know that, they try to avoid that. And avoiding, for example, being treated badly in the healthcare sector is just not seeking healthcare, not calling the ambulance if you are drunk, but staying at home and trying to solve the problem on your own. So the anticipation and the avoidance of public stigma leads to delayed help seeking. And we know from epidemiological studies that in fact, people with substance use disorders in general are very late with seeking help. And I'm sure that the shame of going to your doctor and saying, hello, I think I have a substance use disorder or a substance use problem, it's so uncomfortable, it's so shameful that you try to avoid that as long as possible, which actually makes the problem bigger and not smaller. Which leads me to the next level of stigma. So the first level was public stigma, what do others think about me? But then there's me, myself. And when I notice that I'm drinking too much, I might consider probably I'm developing an alcohol use disorder. And that is also a very painful moment, which I want to illustrate with the progressive model of self-stigma by Patrick Corrigan, which I think is quite useful because we are all aware what others think about people with alcohol use disorders. We know about the stereotypes and the bad image that is attached to that disorder. And to some extent, we share these stereotypes because we are part of our culture and we all have these pictures of people, I don't know, standing in front of the supermarket with their beer cans or whatever and drinking cheap alcohol or whatever, or being homeless or whatever is the stereotype that we associate with alcohol use disorders. And if I'm now considering my own problematic drinking behavior, then I'm confronted with my own stereotypes. Could it be possible that I am one of them? Of course not. I mean, it's me. I'm not homeless. I'm not standing in front of the supermarket. I still have a life, so I can't be the person with the alcohol problem. But if I think I have an alcohol problem, I have to deal with all these stereotypes. So am I a failed person? Am I am I one of them? And the more I agree that I'm one of them, the lower is my self-esteem. I have to concede that I am a failed person. I have an alcohol problem. So, and this all happens before I have spoken to anybody. That is just inside my head, but makes me feel bad. And we all know if someone with a substance use problem feels bad, the easiest thing to do is postpone the problem and consume. I mean, if I'm feeling bad, I might just drink more and think, well, I can still look for help another day. So this threat of self-stigma is also anticipated and it's avoided if I'm ignoring my problem, if I'm denying my problem, if I delay recognition of my problem. I avoid stigmatizing myself. And I think that is a very important reason not to seek help and just to try to normalize my own behavior, because it's so painful for myself to acknowledge that I might have a drinking problem because of all the stereotypes that I know are around and that I might agree with as well. And in fact, we could show that students who are a population with heavy drinking habits, the more negative they think about other people with alcohol problems, the less critical they are with their own drinking behavior. So if I have negative attitudes towards others, I tend to euphemize or to sugarcoat my own drinking behavior. And one antidote to that is that we depart from a black and white picture of I'm either an alcoholic or I'm a normal drinker, and come to a continuum model of problematic alcohol use. And the more people subscribe to this continuum model of alcohol use, the more ready they were to see their own drinking behavior critical, because they didn't have to decide I'm either an alcoholic or not, but I am on a spectrum of more or less problematic drinking behavior, and maybe my behavior is a little bit problematic. And interventions to promote this continuum have proven to be effective, particularly in people with problematic drinking behavior, in making it easier for them to acknowledge their own drinking problem. Then the last column is structural stigma, and it's actually the same thing, that people with substance use disorders and alcohol problems, they're not an important share of the vote, because as a group they are stigmatized and devalued. It is better to be friendly to the people who have healthy drinking habits. I mean, that's the people politicians socialize with and show themselves having a pint with them. But those with the alcohol problem, they're really devalued and are not on the agenda as a vulnerable group that needs particular protection. So there is a lot of structural discrimination and towards people with substance use disorders and towards people with alcohol use disorders in particular. For example, in healthcare, if you have an alcohol use disorder diagnosis, you can be sure that every health practitioner looks at you in some condescending or critical way and is not sure whether he can believe what you say because you have an addiction disorder. So, and to avoid this structural discrimination that also comes with having a diagnosis, it is quite rational to not disclose your drinking habits. So if you see your GP, you're not saying how much you drink. You're trying to paint a slightly more friendly picture of your own drinking habits, because you're afraid that he might just put you in that box of an alcoholic and don't take you serious anymore. And so you see the common effect of all these columns of stigma is that the illness burden is increased because people feel bad, and that makes them drink more. It delays help seeking, or it hinders help seeking altogether. People get inferior health care if they have a substance use disorder diagnosis, because they're treated badly by other health professionals, even for problems that are unrelated to their drinking or a substance use problem. And generally, we have a lot of criminalization for people who use illegal drugs, and social exclusion of people who have an alcohol use disorder. But wait, I mean, I started with saying that it's responsibility and blame that is at the core of the alcohol use disorder stigma. And obviously, there is some sort of responsibility about how much I drink and when I drink. And I think we all agree that without responsibility, we can't treat alcohol use disorder, we can't deal with alcohol use disorder. I mean, there is responsibility. So we need a good concept of responsibility that is not stigmatizing, but that is actually helpful and I think is also realistic. And that is our dynamic model of responsibility that complements individual responsibility with social responsibility, because they are really connected. And this also relates to the continuum of alcohol use and alcohol use disorder. So on the right-hand side, you're on the healthy side. And on that side, you can take a lot of individual responsibility. You can just decide, do I want to drink or not? But there is still some social responsibility, because it's not only me who decides how much I drink, it's also the circumstances. It's my drinking culture. It's, am I invited to drink, and how available is alcohol? But still, it's me who can make an informed decision. But when I get an alcohol use disorder and I develop a dependency, then my ability to take individual responsibility declines, and social responsibility is more and more important. So if I'm addicted, then it's really important how available alcohol is, or how much help I get. And if I'm completely drunk and lying on the street and I'm kind of unconsciousness, then I have no way of just exerting any individual responsibility. Then I'm completely dependent on somebody to help me. So the severity of alcohol use disorder increases the need for social responsibility, and recovery, in contrast, is the process of regaining individual responsibility. So individual responsibility is the result of recovery, but it's not the premise. Because oftentimes you see, you have an argument that people, they need to be motivated, they need to take responsibility to get out of their addiction. And of course, I mean, there is a tiny bit of responsibility that a person has to take, just they have to be ready and willing to undertake treatment. But it's even on a neurobiological basis, it's recovering from addiction means that it is a process that encompasses the retaking of personal responsibility. And when you talk about social responsibility, that's really a complex on many levels. That's our drinking culture, that is alcohol policies, that is the availability of early interventions, of prevention, that is accessible healthcare, and of course, it's how we deal with people with alcohol problems, whether we help them or whether we exclude them. This leads me to my last point. We had this brilliant Lancet series on the commercial determinants of health, and they identified 4 industries: tobacco, unhealthy food, fossil fuel, and alcohol, who kind of pursue their corporate interest on the cost of global health, and they are responsible for an incredible amount of global burden of disease. And I think the alcohol industry in particular uses stigma as a tool to advance their corporate interests. Because when you look, and this is a German example, but I think you have this probably in many countries, when you look at the public relation of the lobby organizations of the alcohol industry, you find a lot of talk about responsibility, because that's their narrative. It's individual responsibility, the informed citizen who can make an individual informed decision how to drink, and the government should not interfere with that decision because we are all grown up. I mean, we know what we want, and we just need to inform them. But obviously, this is ignoring the social part of responsibility. This is really ignoring the other part, and it is clearly it is to the bad of people of vulnerable people, of people at risk of addiction, or people who have an addiction, because their capability of individual responsibility is impaired, and they need the social environment to live up to the social responsibility, really. So the flip side of a responsibility narrative is also blame. If I'm not able to take that responsibility, obviously I'm to blame. And that is really unfair, because it's kind of, it is playing the majority who is enjoying their drinking against the minority, the invisible, stigmatized, devalued minority that is socially excluded, that has little political power, and who are kind of left alone with all these reluctance to implement helpful alcohol policies. And I think the brilliant thing about Scotland is that we now actually know that there are policies that can be implemented and then are helpful exactly to those people. And Scotland not only has good alcohol policies, I think they also developed a really excellent approach to substance use disorder in general and to the stigma of substance use disorders, because a lot of stigma, I mean, it's blame overall. And for people with substance use disorders to speak up and to protest against stigma is particularly difficult, because they are seen so heavily as having failed. And it takes a lot of courage to say, well, I had a substance use disorder, or there has been a substance use disorder in my family, or I'm still struggling with substance use. And in Scotland, they have this recovery walk, which is people who are in recovery of addiction meeting. It's a big event. They're coming with their families. They're showing that they are responsible parents, that they have overcome addiction, and they're public, and it's fun. And I think this is so inspiring, and it's really the opposite of these anonymous self-help groups where people try to hide their addiction and try to stay below the radar just to avoid stigma. This is the way to counter stigma, just to say, we are here, we are many, we are fun, and we are good people. And look at us, we made it, because people who have overcome addiction really are heroes. And because addiction is so prevalent, there are so many heroes, but their stories are just not heard of because of stigma. Because stigma also prevents us from hearing these inspiring stories. And so this is my last slide. I want to conclude with this note that we need a more open and more positive way of dealing with addiction to overcome the stigma of substance use disorders. And that's it. Thank you for your attention.
Thank you very much, Professor Schomerus. It's been a great presentation, and again, highlighting the stigma that is present and that we see every day in attempts to implement the policies, and in any attempts also even to support the health system and healthcare providers. So I think that you have highlighted very well how this is seen as a personal failure, and how industry uses this so well to continue their agenda in making sure that people use more and consume more, and leading to more harm in the society. So thank you for really highlighting very important points that need to be approached also from the policy side. And I think that in the chat we're having some reactions as well. So thank you for that. So I think we now move into some question and answers. And Maria, if there's anything in the chat or in the Q&A.
Thank you very much, Karina. So far, there is nothing. So let's give it some time. We have still some minutes until the end of the webinar. And also, thank you very much from my end. I learned a lot. It's very inspiring. And if I may, I have one question to Baroness Ilora Finlay. What were the reactions of the public once this, once you published this report? What were basically, maybe 2 or 3 key experiences that you would like to share with us, also in relation to what Georg was saying? Because I mean, those things that you have shown at the very beginning, specifically to the violence and the families, those are very powerful things. And how have you in your correspondents try to adopt also this positive language, because I loved how Professor Schomerus, this end of this positive note and those examples from Scotland, they're very inspiring, but at the same time I imagine it was not so rosy, the first reactions of the public, but maybe those are just my assumptions. Over to you.
Okay, thank you. Actually, the reactions of the public are really difficult to gauge, because you have to look at what gets out in the press and the media generally. I think that there wasn't as much press coverage as we would have liked. And my guess is that, of course, those who are selling alcohol, who make a profit out of it, didn't particularly want there to be a huge amount. I certainly got targeted by campaigns such as Drink Aware, which are funded by the drinks industry, which are trying to promote so-called safe levels of drinking. But there are all kinds of mixed messages in there. First of all, they're funded by the drinks industry, so you have to ask, well, who's got an interest in this? But also, the messages are subliminal, that it's absolutely fine to drink socially. It's only if you run into a problem, as Georg has shown us this morning, that somehow you're a weaker human being. And I've even come across programs that have tried to target into schools about safe drinking. Now, I think that we should be targeting into schools about not drinking and not taking drugs. We should be targeting into schools about sport, about healthy eating, and so on. So I worry that any curriculum time even is being taken up under a guise which initially looks fine, but then doesn't actually say how to spot if you're beginning to get into a problem, what to do if you think your parents or your grandparents or your aunt or uncle have got a problem, or what to do if an older sibling does. An area where we had a pretty good reception actually has been in Parliament itself, because obviously there are politicians who've been on the receiving end of the harms of alcohol, who've had alcoholic parents and so on, and have set up groups in Parliament to look at that. And so that's been welcome, and that's where support for the legislative moves have come from. But I worry that the Treasury gets influenced by talk about revenues from tax coming in and jobs in the alcohol industry, and how that potentially can undermine the message that actually you really don't need to drink to have a healthy life.
Thank you very much. And as you mentioned, I think that this need to subscribe to the continuum of drinking problems is very important, because it's true that every time you are pushed in any dialogue you have with anyone is, either you are an alcoholic or you're not an alcoholic. And, this notion of the harm and the continuity, the continuum of drinking problems is not there, and this is something which is critical for this clarity in the discourse, so that we are not manipulated into these subliminal messages or contents on responsible drinking. If you do not handle the drink, you will have a problem. You are an alcoholic, and it's not about that.
Yeah, can I just, I've just seen in the chat from Britta Jakobsen a question about pushback. A very close friend of mine, particularly of my husband's, was a general practitioner and had an alcohol problem. And he had the courage to come out and speak openly. His name was Mike Wilkes. He has subsequently died. And sadly died young, not because of alcohol, but because of a malignancy. And we know malignancy, of course, is associated with high alcohol consumption. But he spoke openly about it and began to get the British Medical Association to recognise the problem of alcohol abuse in doctors in particular. But it took huge, huge courage to do that. And I think nobody should underestimate the courage needed. And it was actually his courage in a way that inspired me to feel that in honor of his memory, I needed to pick up the baton, if you like, of what he'd started. Out of respect for him, he was a very, very fine man, a very good doctor, and had a lot of background that one would understand how his addiction escalated. So I don't think anyone should underestimate the courage it takes to admit that there's a problem.
If I can just add to that, I think we need to create an environment where it is easier, or where people are welcome to share their story. I mean, that's up to us, and that's our attitude. If I'm a doctor in office, I have to be valuing towards people who have an addiction and talk about them. I really have to stop myself of being condescending and to try feeling I'm superior because I don't have this problem. We really have to validate them for their courage and create an environment that makes it as easy as possible to share this without shame and without because we can all imagine how difficult it is to acknowledge that to oneself and then to acknowledge it to other people. That's I think that's really yeah, and we need people with substance disorders to come out and share their stories, because that's the only way actually to challenge or to change the stigma of substance disorders.
Yeah. Can I just add to that too? I think there are two ways of sharing the story. Some people want to then go public and have the courage to do that and take what it goes. There are a lot of other people who need the courage to go along to something like Alcoholics Anonymous and to share in a safe environment with people. So Clive Brook has instigated an AA group within Parliament, specifically for parliamentarians and staff. And again, you know, I really admire him for having done that. The way he's done it, it's completely confidential. We, you know, none of us know who goes or who doesn't go, whatever, that's up to them. But again, it's internally recognizing that you've got a problem, and then having a mechanism that feels safe to tackle that problem.
Maria, anything else in the chat or any questions?
I think one of the things was just answered by both speakers in terms of like, how do we also create this change within healthcare professionals? I don't know if Georg, you specifically would like also to share some of your experiences on this as someone who is the chair of a psychiatric department. And then Marina was also raising her hand very patiently, and I think she also had questions in relation to that.
I hand over to Marina.
Yeah, hi. Thank you a lot for like really great and powerful like presentations. I like my question is really kind of related to the thing that how like do you know about any like interventions which help actually people to like to empower them to share their stories, to empower them to deal with stigma? Because I really think that, yeah, like recovery work is really like cool. I just saw great, like I'm so glad to see this alive. Like, you know, I'm from Russia and I really have problems to imagine something like this in Russia in these days, because it's like really a huge stigmatized, like alcohol use and like drug use. It's like very stigmatized conditions in Russia, is like in a lot of countries around the world. But I think that you know, it's really hard to change public view on alcohol use disorder, but can we do something on like individual level, like, you know, to people who already have this like alcohol use disorder and they don't have time to wait until like public change their view on this? and how we can like empower them, how we can like help on probably in medical settings or in other settings like in social different like, social institutes. Is it make sense my questions to you? And
Please go ahead.
okay.
Yeah.
May I answer? Yeah, absolutely. It's a great question because it just shows us that we need activities on many levels. I think what Ilona said, it's right. The first thing would be to connect people to others with substance use disorders in the self-help groups and to empower them to share their stories among them, because that's the first step, and that is empowering just to see that you're not alone, that there are others who have similar problems. Another thing is that we as health professionals need to promote a dimensional model of substance use problems, because this black and white model, you are either you have no problem or you are an alcoholic, is so unhelpful because it stigmatizes the quote alcoholic, and it kind of minimizes the problems of everybody else. And both is not the right thing to do. We need to communicate that drinking per se is a health risk, is damaging your health, and the more you drink, the worse, and the less you drink, the better. So at every point, you can improve your health by reducing your drinking. And I think a dimensional model of drinking problems helps us to tackle stigma and to get people into a process of recovery at any stage. So that, and that is not, I mean, there are still many people who say, well, people need to fall really low until they really feel the consequences, and then we can start helping them. And I think that's a disastrous narrative, because that is kind of waiting for them to really be hit rock bottom, and then you can build them up again. And I think that's just a very a wrong approach. That is, and from that on, I mean, there are many ways to encourage people to share their story publicly, but obviously, as we have heard, that is something that is deeply personal, and that is nothing that we can decide. That is something that we have to be grateful if people find the courage to do that, and we have to applaud them and support them, I think.
Can I just add very briefly to that? I do think that legislation gives public health messages. We saw it with smoking. Banning smoking in public places resulted in a drop in cigarette consumption. That's why the tobacco industry then developed vaping, unfortunately. But you know, the other thing is that you have to remember that people selling addictive substances are always going to try and be one step ahead of you. So there's something about helping the next generation almost immunize themselves against addictive potentials. That's really hard. And I think that's a separate thing, which is about changing the social message so that it's really cool to drink non-alcoholic drinks, that, you know, zero alcohol beer tastes great, and so on, so that you create a culture around, for instance, alcohol-free cocktails, so that at an event you would expect people to serve alcohol-free cocktails, and they look better and more exciting than the glass of white wine or red wine, so that you switch the tone in a society, and you make it really cool to not drink. And then you need some really high profile figures like sporting figures to come out and attribute their great success to the fact that they don't drink alcohol, and that they stay fit and so on. So that there are two really big aspects. One is legislation gives a very clear message. That's why I want the drink driving laws changed. That's why I want more minimum unit pricing. That comes through clear message in legislation. That's a public health message. The other one is the tone in society, that it's really cool to not drink. It's really cool to have one of these non-alcoholic cocktails, to serve them, to have non-alcoholic parties, so much more fun, etc. And then the last one is to not be scared of pointing out when alcohol has contributed to some kind of disaster. So domestic abuse, we had a lot of speeches in the domestic abuse spill about the effect of alcohol on domestic abuse. When someone's killed in a road accident, we need to be quite upfront about the role that alcohol played in that, and so on, and point out that really it's very old-fashioned to go and get drunk. It's modern to not be drunk.
Thank you very much. And we are now at the close of the event with these very positive messages, and then on the need to switch the tone and to switch the way we approach alcohol consumption. Even at low levels, it brings harms, and it is a very important aspect that also needs to be recognized across the society. So changing the tone, changing the narrative, disrupting the beliefs that we have that it's only at high levels that alcohol causes harm. And that, again, we are all part of a society that needs also to bring the evidence into the policy and point to the fact that there needs to be a societal change in the way we lead with these harmful and toxic substances. So thank you very much for this and for bringing this topic to our network. I wish you all a very good day and a continuation of these discussions and the contribution to this very needed and difficult agenda. So thank you very much for this and for this very exciting session. Thank you.